So the clinical team at the Maudsley Hospital in London have just released a paper entitled The Top 10 Misconceptions About CBT-f-DDD. So we are here today to discuss the paper with them and ask them questions all about it.
So my name is Katja Schulze, I'm a clinical psychologist and I work in CADAT, in part in the Depersonalisation-Derealisation clinic.
Hi, my name's Dr. Claudia Hallett. I'm a clinical psychologist and the clinical lead of the Depersonalisation-Derealisation disorder service at the Centre for Anxiety Disorders and Trauma.
Hi, I'm Tom Parsloe. I'm a clinical psychologist at the Depersonalisation and Derealisation disorder service at South London and Maudsley. And I'm here to talk about our new paper on 10 misconceptions on CBT for depersonalisation and derealisation.
I guess it was just a conversation that we started amongst ourselves in clinic, thinking about the typical things that we were seeing that our patients were bringing, and within kind of service provision, what people were saying to us about the need for a specialist service. And it just got us thinking about, are there some assumptions and misconceptions that people are holding both at a kind of clinician level and a kind of client level that we could say something and speak to that would help kind of reduce some anxiety and confusion around what can be a really confusing disorder.
We find that often people who we feel could be helping clients with this kind of problem in other services don't feel confident enough to do it and feel like they need to refer them to a specialist team, when often we feel like actually they could be doing that work, and those people might not need to wait so long to get help.
The main aim with that really is to sort of help people understand the condition a bit more, and also to see if we can generate a bit more hope around CBT, so cognitive behavioural therapy, for the condition.
Misconception number one is that DPDR is rare. A lot of people seem to think this, and actually it's actually something that people experience quite frequently if they're tired or stressed, or if they have medical conditions. And it's also something that can be experienced as part of quite a lot of different psychological problems, like panic or depression, OCD, PTSD. People can also experience it if they have conditions like temporal lobe epilepsy, or in the context of taking recreational drugs, or sometimes after taking prescribed medications. It seems like actually it's pretty common in the general population. It's about 1 to 2% of people who experience clinically significant DPDR. And that's actually really interesting when you consider that something that most people would be much more familiar with, like a condition like obsessive compulsive disorder, has quite a similar prevalence rate. So it's be about 1.2%. If you think about how big the population is, 1 to 2% of people with DPDR is actually a huge number of people. If you think there's, I don't know what the population is today, but I think when we wrote the paper it was something like 68 million, so that's around about 700,000, 1.4 million, something like that. The UK Rare Diseases Framework defines rare as only 1 in 2,000, a disease affecting that kind of number. And I think it's actually potentially quite unhelpful for people, because it might contribute to them feeling more isolated if they think they've got something really, really unusual. Possibly some of the reasons that this misconception exists are that firstly, it's quite difficult to describe the problem to people. It's hard to articulate the symptoms. If you talk about feeling a bit strange, or like you're not quite here, or feeling a bit unreal, a lot of clinicians might find it harder to pick that up or recognise what's being talked about. So because of that, I think people their DPDR might not get identified, or they might get misdiagnosed sometimes. And as well as that, there isn't an awful lot on DPDR in training courses for therapists, for example, so therapists might not always be that aware of it. So yeah, there seem to be quite a lot of reasons it might not get picked up, and we really want to challenge that, because if that happens, it's sort of perpetuating experiences of neglect for clients who may have had lots of difficulty being heard before and with their journey through services to get help.
Why is it important to talk about how common the condition is?
Well, I think really to dispel this unhelpful conception that it's really rare, because that makes people feel really isolated. And I think if you do that, you can normalise the symptoms. For example, maybe knowing that 23% of people will have had DPDR symptoms on some level in the last year. It can be quite a helpful normalising statistic. So misconception 2 is that DPDR is necessarily complex and pathological, and we don't think that's really accurate. We would say that yes, some DPDR presentations can be complex, but certainly not all, and even if they are complex, that doesn't necessarily mean that it's going to cause problems or complications in the treatment, because even if there are quite a number of maintaining cycles, you can still often address those in fairly straightforward ways during treatment without any particular issues. We tend to feel it's better to approach it using a shared formulation driven approach, where you target unhelpful maintaining cycles. And it's important to keep it simple and make it clear to them what we're trying to do is identify unhelpful appraisals of symptoms, something like rumination or avoidance, symptom checking or seeking reassurance, that's something like that. Focusing more on targeting maintaining cycles like that really does reduce complexity for both the clinician and the client. And it's quite a nice way to work, because you can use quite sort of generic formulations and use tools that will be familiar to most CBT clinicians. Another thing that is really important, though, if they're going to do that, as I mentioned a minute ago, is about managing expectations. Move away from the idea of suggesting that this is about finding a cure, to the aim is more about learning to manage the symptoms, learning to not exacerbate them so much. We don't really feel it is a pathological problem. We think it's a protective, that serves a protective function. If you're feeling very anxious or stressed, it's quite it can be quite difficult to think clearly and make good decisions, helpful decisions. One way of that we seem to have of dealing with that is to suppress or numb that kind of reaction in the short term, because then you might be able to function better and think more clearly and make a better decision. But if you're thinking about it as something pathological and something sort of problematic, then that's probably going to make you focus on the symptoms more and actually try to eradicate them. So that's probably going to backfire, because it usually won't work in the sort of short term, and it's going to make the person more anxious and stressed and probably maintain the symptoms or maybe even make them worse. It's really a sign that this is a brain that is just a bit overstressed, it's a bit too anxious or tired, and it's trying to do exactly what it's supposed to do. It's trying to protect you, but it's maybe just doing that a bit too well, it's overdoing it.
So this misconception is the misconception that DPDR is always PTSD. So this is a really common pairing that we see, that people will come with the assumption that I've got post-traumatic stress disorder in some way, shape or form, and this is what kind of makes sense of my symptoms. And as clinicians, we will sometimes agree that that is right, but it's not always the case. And so I guess we were keen to try and help people expand their understanding of how these symptoms can be not always associated with post-traumatic stress disorder.
Why do you feel it's something you have to speak to? What's the kind of problematic things that kind of come around people having that assumption?
Essentially, it's the kind of the rigidity that a clinician might bring to the piece of work with somebody, of assuming that this is a PTSD presentation, therefore we need to run with a kind of PTSD specific treatment. What we're trying to advocate for is a kind of broader conceptualisation where people kind of remain curious, clinicians, especially when they are assessing people with DPDR symptoms, to not just automatically assume post-traumatic stress disorder, but to think widely about, is this related to trauma or is it not? Some clients will automatically assume I must have had a trauma or a big T trauma where there was an incident that must have caused this, and sometimes that's not the case.
Within kind of your training, is there a sense of where this idea of the link comes from?
Yeah, absolutely, because as clinicians, when we're trained in cognitive behavioural therapy for trauma and anxiety disorders, there's a heavy emphasis on dissociation being linked to post-traumatic stress disorder. So it may be the case that clinicians have only really come across the term dissociation in relation to their understanding of PTSD work. So it's kind of no wonder in some ways that many clinicians might hold this pairing of dissociation and therefore by association DPDR being a kind of PTSD kind of component. And so whilst that is true, it's not exclusively true for these symptoms. I do think it's probably to do with the training we receive on this and a lack of general dissociation and DPD specific teaching and training on both kind of CBT training courses and broader psychotherapy training courses.
If a patient and clinician go maybe erroneously into that therapeutic space with that misunderstanding, what the kind of risks that can arise in that space then?
I think for all good psychotherapies to work effectively, the collaboration has got to be there from you both working on the same page and having a kind of really good shared understanding of what these kind of difficulties are about. And that's why I guess in this paper we're really trying to emphasise collaborative formulation, and if one party is assuming kind of quite rigidly that it's to do with one thing, you miss having a kind of broader conversation and seeing what other explanations there could be. So I guess we're trying to encourage that curiosity from both standpoints. The client as well to be open-minded about where these symptoms may have come from and that may or may not be related to trauma and PTSD.
One belief that I guess we often come across is that the symptoms of depersonalisation and derealisation, once someone is experiencing them, are fixed and static. And I guess what people often imply by that is that they're not changeable or not amenable to change. We find that is a misconception that's common in some therapists, but also in some of the clients that we see.
What is the I know the question, it's just the words for the question.
Why does it matter?
Yeah, essentially,
yeah.
What's the importance of that? So if people have that belief, what's the knock-on effect of that?
Yeah, it's a good question. So I think why it's important and why it matters is sort of on the therapist level, it can leave people maybe feeling a bit pessimistic about psychological treatment for clients who present with depersonalisation, derealisation. It might mean that in therapy the focus moves to things which aren't the DPDR, which often is the most distressing experience for the person, but the focus is maybe more on anxiety or depression or other difficulties. And in sort of worst case scenario, people aren't offered psychological treatment because there is maybe the misperception that nothing can be done. I think it's not too dissimilar in clients, come to therapy feeling maybe a bit hopeless, feeling very stuck and feeling a bit condemned to live in a particular way with a lot of suffering, indefinitely, I guess.
How would you challenge that belief?
So there are many different factors that seem to kind of correlate with depersonalisation, derealisation, and also evidence that when you take samples of people's experience across time at different time points, there is variation within people. So all of that, I guess, speaks to the fact that these experiences can definitely vary and fluctuate over time across a range of different clinical and non-clinical populations.
So there were a few kind of questions that we had.
Can I say one more thing?
So absolutely. Yeah,
so I suppose those are maybe studies which often talk about the DPDR maybe more at a sort of population level or at a group level. I think we also want to really bring that to our work with the individual client, and I think that's where obviously where our work is. And I think we find it helpful to sort of elicit some of these beliefs, really understand maybe where they come from, and then see if we can get the person on board with sort of testing out some of those beliefs, especially if they're contributing to a degree of helplessness and hopelessness in therapy. So ways we might do that would be to experiment in the session with changing some of the things that might influence the experience. So that could be attentional focus or, using certain triggers to see how that impacts the person's experience. We might kind of get the person to keep some personalised diaries that look at, maybe their experience of DPDR, as well as sort of the distress associated with it at different times during their week. That can help us understand, what might be contributing to their experience.
So is there a way of kind of speaking to how clinicians and patients engage in that space so it doesn't feel
I think it's
invalidating
a really
and it's
question,
kind of
it is a bit, it's definitely tricky to find the right balance, but I think there is, so I guess maybe having looked at whether there is any fluctuation, which doesn't necessarily mean that there are periods where the DPDR is completely gone, right? We still come across people, or we still work with lots of people who have sort of chronic experiences of DPDR, maybe with some fluctuation within that. And I think it's important to acknowledge that that's obviously the person's experience, and to kind of really figure out what's the distress that, people who come to therapy typically do come because there's a level of distress. I guess it's really understanding how experiencing those symptoms then leads to the distress or interferes with quality of life, and looking at maybe a bit more the relationship that the person has with those symptoms, how they try to manage them in the moment, and thinking whether there's something we can improve there, so more around the distress and the impact. We don't want to just push towards the person, using grounding to get rid of something which they've probably tried 100,000 times and haven't succeeded in. That's why we might be thinking more about interpretations, about meanings, about relationship with the condition, and using the formulation to really understand that together, and then think about different ways of working with that.
It's tricky trying to have the hope that it can improve, and having faith in the process of CBT for DDD. But at the same time, I know I've had it for quite a few years now, and it's quite difficult kind of aligning the two in a way that gives you hope but also realism. I know certainly we hear at the charity quite often that people might come to a psychologist or a specialist social whatever, and the aim isn't to really kind of try and improve the symptoms, it's more to kind of live with the symptoms, and it's that's quite a difficult thing to deal with.
Definitely. I think one additional point, maybe then just picking up on something you've just said, is that sometimes in the work we can also think about making space for some of the really important sense of loss, maybe around and a life that the person might have wished to have, or an experience that might have wished to have that hasn't materialized, I guess, and hasn't happened. And I suppose not sort of to deny that, but also to think about how to again helpfully relate to that, for it not to take over and sort of cause more distress, but also not to dismiss it and deny it. And again, finding for each individual where that balance is and what that looks like then in practice day to day. Can be an important part of the work where people have lived with a condition for an incredibly long period of time. So I think one assumption or belief that we come across is that there's no evidence that CBT for DDD is effective. And I think we need to be very transparent and upfront and acknowledge that there really is a lack of sort of high quality, sort of gold standard research, such as randomized controlled trials, for example, of CBT in this population. But on the other hand, I think there is a lot of sort of detail in what in the data that's out there that we can look at, and also, I guess, clinical expertise that we can bring to this that at least leaves us with a degree of cautious optimism. What we find is sometimes people are maybe being prevented from accessing treatment because it's not deemed a sort of evidence-based intervention. And I can see how that comes from a place of wanting to do the best and right by the person, but at the same time maybe leaves some people missing out on some of the benefits they could get. I guess the studies that are out there are often on small samples. Maybe there's sort of heterogeneity across the different studies, and maybe the time frame or the way that the study is designed isn't ideal. But it's useful to highlight that, for example, Elaine Hunter's study that looked at a sort of waitlist control found that people who during the phase of treatment actually had benefits in terms of their DDD symptoms, anxiety and depression, compared to the time that they were waiting on the control list. And that was, CBT focused on the DDD specifically. And I guess also then more recently, the feasibility trial for DDD intervention, CBT-based DDD intervention, in talking therapies also kind of spoke to the potential usefulness and sort of improvements in terms of healthcare costs that the intervention might possibly offer. There's need to follow that up with bigger samples, I think. There's also maybe from other populations some more indirect evidence that tools that we typically do use in CBT can change the experience of depersonalization, derealisation symptoms for people. We do think that probably generic, formulation-based CBT has got a lot to offer to many people with depersonalization, derealisation disorder, and then there are probably some people who would really benefit from a much more specialist approach, like there is for OCD or other disorders, right? When we look in detail at what maybe was the mechanism of change, it is things such as how people pay attention in the moment, maybe how they interpret particular experiences, or how they're coping with their emotions. And I suppose those are all things which in CBT practice we can work with, whether that relates to DPDR or other things. So it's a generic skill, but that can be applied to that specific presentation.
So this misconception is the misconception that only specialist clinicians can treat DPDR symptoms. We think that this misconception is probably held at a number of layers within the system, that kind of clinicians themselves might find themselves holding it like, I don't know enough about this condition to be able to treat it, I've never worked with someone like this, so I therefore won't have enough skill or knowledge to treat somebody with this, and so will often kind of undermine themselves possibly or not have enough confidence to give the work a go, when we would argue actually probably if you're a very competent CBT therapist, you've got some good enough skills to do this work. I think it also speaks to the earlier point about lack of teaching and training that feeds that confidence, that clinicians may feel de-skilled because they don't have the right resource or supervision to support that work, which may be the case. But it can also be a kind of systemic problem where services will think, oh, that's not for our service, that needs a specialist input, which I think does clients not such a good favour when they've got this, as we know, kind of 7 to 12 year therefore wait on the right assessment or the right diagnosis for their problems. And so I think we were just really keen with this one for stopping that kind of problem, therefore, where clinical services that are highly specialist are the ones that are seen as the only ones that can do this work, whereas we would encourage that there are multiple levels of our NHS kind of talking therapy services and secondary care services that can be doing this work as well.
Is it that any trained and accredited clinician can work with anyone with DPDR, or is there kind of other minimum kind of training and awareness that would be a good idea?
Yeah, I guess in this paper we're talking specifically about cognitive behavioural therapy for DPD and DPDR. So our hope and our kind of encouragement is for those who are well versed in the cognitive behavioural therapy model, there is so much that you already have and know. It's about tailoring those skills to the needs of our DPD DR clients, and so that might just be about seeking specialist kind of supervision and resources and getting to learn the kind of model and formulation with that work, rather than assuming it's wildly different from your kind of bread and butter skills. So when people come to us reflecting on their CBT journey so far, one of the common themes that come up of people saying, I've had CBD before but it hasn't really worked for me because it hasn't been targeted or highly specialist enough. And so there makes a problem in the system, I think, when people are not targeting the CBT to the depersonalisation. So I think we could do better in our kind of primary and secondary care services when these symptoms are really held in mind with the model. So the symptoms aren't ignored, but they're central to the formulation.
And what exactly does that mean? Does that mean using the kind of core principles, foundations of CBT to identify what might have been kind of causing, contributing, maintaining those symptoms? Is that what that means?
It does, and also just not ignored as a symptom, because I think sometimes a clinician might hear it and slightly go, I'm not quite sure about that, and therefore focus on something that's more familiar, like the anxiety or the kind of low mood component, and kind of pick a CBT treatment package that will feel more familiar to them, and clients will often say, but they didn't speak about my DPDR, or we didn't kind of include that in what we're speaking about, and that was the real primary focus for me. So they might often feel kind of dismissed or not really their main presenting problem being treated as the main presenting problem.
And is that something you can do kind of using CBT techniques, or is it a good idea to kind of look at CBT for DDD training? And if so, is there a place that clinicians can find that?
Yeah, both things are really good. So we will provide kind of training and specialist supervision for services where that's required. But there are resources obviously that you guys have got on your website, and kind of this paper will go to helping clinicians just upskill themselves a bit if they're feeling underconfident in knowing where to start with, how they would tailor their CBT treatment that they are already offering to folks with DPDR.
Misconception number 7 is that a clinician needs to have a protocol to for them to be able to treat DPDR effectively, and this is something that I suppose comes about partly because protocol-driven treatments are very common, they're very widespread in psychological services. However, there isn't a CBT protocol for DPDR. DPDR symptoms are really quite diverse. They're quite idiosyncratic in terms of the quite wide range of symptoms that people may or may not have. And also, when you think about people's formative experiences for people who have DPDR, they can also be really quite varied. You know, some people might have experienced emotional neglect or absent parent. Others might have they might have had some really chronic stress going on in their adulthood, or they might have lots of different comorbidities. So there's really quite a range. And also, people with DPDR might have quite a range of appraisals of symptoms, as some people might sort of be feeling like means that they're different, or they're alone, or somebody else might be feeling that the symptoms mean they can't function. Another person might be feeling that, if, for example, somebody who's got them in the context of having taken recreational drugs might be blaming themselves and saying, oh, well, I've broken my brain, that sort of thing. Similarly, quite different goals and different maintaining cycles. So we find it more helpful to use a shared case formulation for working on DPDR, because we think that if you follow a protocol, then there's a risk of that not really capturing all those different idiosyncrasies that I mentioned, and if they don't, then it could really feel like it's quite a poor fit, and it's not really very, it feels a bit impersonal to the client, and that's something I think you really particularly want to avoid for this client group, because they've often had so many experiences of not being heard by services and so on, so we don't want to add to that experience again. So misconception number 8 is that DPDR symptoms are in themselves really dangerous somehow. So they might be fearing that the symptoms mean they're going to go completely insane, or they're going to lose control completely, or they're going to do something really dangerous, or perhaps do something sort of highly socially inappropriate. And actually, the evidence, well, there isn't really much evidence that DPDR symptoms in themselves are dangerous. I think when people don't know that much about it, they can sometimes notice that there are some shared features between DPDR and some other conditions. So, for example, some neurological conditions, if you're thinking about Parkinson's or dementia, people might have difficulties like brain fog, for example, or absences. So you can see why people might sort of think, oh, does that mean I'm, got this kind of condition? Or when people with DPDR have neuropsychological tests or brain scans, they usually have normal results, which doesn't really sort of fit with that fear. And similarly, people with DPDR might also be aware that with some other kind of conditions like psychosis or other dissociative disorders, like dissociative identity disorder, people with those can sometimes experience DPDR symptoms too. So they might understandably kind of worry that maybe they've got a more severe mental health problem than DPDR. But again, usually that's not what happens. People don't develop psychosis because they've got DPDR. They don't have. They don't end up having neurological or physical damage because of the DPDR symptoms. The problem with seeing them as dangerous is that if you think they're dangerous, you're probably going to ruminate about it much more and think about the symptoms more and try to make them go away or try to not exacerbate them. That kind of solution can end up really restricting what somebody is able to do in their life if they're avoiding lots of triggers. So it can end up actually having more of an impact than the DPDR. It's more helpful, as well as sort of explaining that, you know, that there isn't really much evidence that it's dangerous. Trying to get people to do experiments to test out these beliefs, because that can really reduce the fear about what the symptoms mean.
In practice, how do you validate that distress but while still correcting those misbeliefs?
Sure,
because that must be a really hard thing to balance. You don't want to invalidate how distressing that is for that person.
Absolutely not. No, they are. No, thanks for saying that. It is really important to say that. Yeah, they are really distressing for a lot of people, and so you absolutely need to normalise that and not dismiss that. Sensitively trying to think about what they would like to be able to do that they've been too scared of to do because of this belief, and trying to help them take that risk to sort of do something that's doesn't feel too risky for them, but it's something that's a bit out of their comfort zone. And then there is an association between DPDR symptoms and suicide, and it's important to be really mindful of potential risks and assessing people for risk when you're a clinician working with them, as you would with any mental health problem. So that wouldn't really sort of be different for DPDR. Making sure you put into place a really good safety plan. So I think often if you do that in a sensitive way at the beginning, it's actually more containing for people than if it isn't discussed.
So this misconception is a kind of patient quote version which says, all I need is for the symptoms to go away, and without them life would be better. So this is a sort of summary essence and feeling that we get from clients who come and see us about, I guess, the desperation that you will sort of well know of what it means to live with these symptoms day in, day out, and the relentlessness of them, and the really unpleasant nature of them, that there's often a really high hope that when they come to seek treatment, that the clinician will be able to just wave a magic wand and they'll all disappear. And that is a hope that we see kind of time and time again with the clients in our service, and it's so understandable given how distressing their road has been with these symptoms. And as clinicians, we just have to kind of do that delicate conversation with people about where that obvious, understandable desire is to be free of these symptoms, versus giving them some hope and encouragement that they're really understandable symptoms that aren't inherently dangerous, and they are something to explore, to understand and to make sense of, that don't need eradicating, just like we wouldn't eradicate anxiety from somebody's kind of body or depression or low mood. All of these emotions are kind of part of our human experience and normal to some extent as the brain's way of coping and processing difficult information. So there's often a kind of a conversation to be had if people come in with this really high expectation that the only cure that they need is for these symptoms to go away. It can be a bit more nuanced.
Can that cause kind of teething issues with how you work with a person?
I suppose it's just that mismatch between expectation and kind of what the clinician might be able to promise or do in a short time frame of treatment. That if somebody is very wedded on, I just need a cure and I just need a fix, and if within the first sessions of therapy that doesn't look like it's going to be forthcoming in the kind of time frame that they might want it to, they might just dismiss therapy quite quickly because it hasn't kind of produced the quick fix goods, if you like, for what they were hoping for. And I think that can be a shame on somebody's path to understanding DPDR if they are quite fixed in that mindset. And maybe don't give themselves a chance for an alternative explanation to develop over the course of therapy with kind of clinical work that involves. But it's also understandable that people are just desperate to be rid of these symptoms, and psychotherapy isn't a kind of quick fix solution to symptom management for any disorder.
So from the kind of clinician point of view, how do you approach people coming to you with these kind of thoughts and ideas and saying those kinds of things?
Yeah, I mean, I absolutely, want to be on the same page with someone, that I want your life to be less distressing in the same way that you want there to be less distress as well. So there is collaboration in that team approach. We do want you to be able to live better with these sensations, causing less of a problem in your day-to-day life. And whether that means complete eradication and you'll never feel them again, for some patients it does. For others, it's something that they've always lived alongside and will continue to live alongside, but we can reduce the distress that they cause and we can improve somebody's functioning and quality of life. It's a very individual journey depending on what's triggered these sensations for somebody in the first place. So there is hope that we are both working for a common goal of this to be less of an issue for that person's life, but it doesn't always equal the magic wand solution of this is never a felt sensation in their body again.
Does this touch on the idea of acceptance? So the reason I'm asking is we get a lot of people conflating acceptance with rolling over. So I'm going to accept that I have these symptoms, that means I'm not going to do anything about them and I'm just going to let them. Does it touch on that?
People who jump to that conclusion too quickly, they're kind of like, I've just got to accept this. It almost invalidates that journey, that emotional experience with it. And I think psychotherapy and CBT is a place where we'd want to make room for that, to think about your relationship to the DPDR, to understand it fully, to not just think, oh, this is here forever, I've got to resign myself to the fact that this will never go, but really get curious about it and try and understand how it's developed, what it's there, what the purpose is, what the function is, how actually sometimes people can see it as a helpful thing in their life, something that's been protective, and they often haven't reflected on that as a potential beneficial kind of strategy for them to have survived many things in their life. So I think it's people's relationships to the DPDR that's really key for us to be exploring in therapy. And whether that lands on an acceptance path or not, it may be the case for some, but it may not be for another. I think I wouldn't want to impose that on anyone's journey.
I guess this is a misconception that we come across in people who are maybe being referred to the service or come for assessment or even at the start of treatment, which is only the latest medication or new therapeutic model will work. And I think it's a really understandable one, because people, I guess, who kind of come along with that belief do so for very good and important reasons, and it's typically based on their experience and based on messages they might have been given by healthcare providers or other services or other service users or have read online. So I think it's really understandable people come with that belief. And it's a really important one, I think, to identify, because it wouldn't be surprising if someone with that belief felt very hopeless and sort of negative, pessimistic about treatment. Now, we know that there's good evidence that the person's expectations about therapy is a factor in the outcome. So we really want to sort of pick up those beliefs really early on, and probably first of all understand how come the person is feeling that way or thinking that way, and also then looking at the sort of costs and benefits of holding on to that belief when they're about to embark on another course of treatment, which will draw on CBT principles and CBT formulations and interventions. So I think it's one to really sort of stand still with at the start of treatment, because it has such an impact maybe on how well people might be able to approach things with an open mind, have a degree of hope for the treatment, and then maybe also actively engage. I think what's the risk with this belief is that it becomes a bit of a self-fulfilling prophecy, because of course if you think something isn't going to work, makes complete sense not to really invest, maybe not to really sort of think things through, not to really contribute. And I think that's counter to, I guess, the kind of collaborative piece of work that we'd hope to have in CBT for it to work well enough. and to have the best chance of, I guess, reducing distress and improving quality of life. Often people have tried CBT and they've had CBT that wasn't focused on what they wanted to work on maybe, or it hasn't been effective for many reasons that we can pick apart. But I guess it is that sort of really important first step of understanding how come the person is sort of coming with that approach, and also then thinking about, okay, what can we do about it, and what could be helpful for you right now in terms of holding on to it or letting go of it. How much can we suspend belief and, you know, experiment with this together. CBT isn't for everyone at every point in their life, and that's okay too. And I think sometimes, you know, after a period of experimenting, we can also agree that this isn't the right time for this treatment for this person at that time, maybe with that clinician, and sometimes that's okay. But I think, you know, having gone through the process of giving it a good go, I think is important.
Thank you for watching this video on the top 10 misconceptions of CBT for DDD. As you know, we're a charity led by people with lived experience of the condition, so we would love to know what you think. Either let us know in the comments or get in touch with the charity by email.